Hello, I am Dr. Riddhi Danak, Assistant Professor in Cvts Department at UNMICRC Institute of Cardiology and Research Center. Today I will be discussing about the anatomy of the mitral and the tricuspid valve. The atrioventricular valves, that is the mitral and the tricuspid valves, are different from the arterial valves, that is the aortic and the pulmonary valves, in their constitution and physiology. The atrioventricular valves are highly asymmetric structures having a septal and a mural leaflet and a well-developed subvalvular apparatus, whereas the arterial valves have a more symmetrical tripartite outline, though not perfectly symmetrical, with the three leaflets suspended in a particular milieu.
Right.
This is a diagrammatic representation of the atrioventricular valves and the pulmonary and the aortic valve also. This is the pulmonary valve, this is the aortic valve, this is the mitral valve and the tricuspid valve. The aortic valve and the mitral valve are in fibrous continuity with each other, whereas there is no fibrous continuity between the pulmonary and the tricuspid valve due to presence of subpulmonary conus, and there is absorption of the subaortic conus during the embryonic development, and so the aortic and the mitral valve are in fibrous continuity with each other. This is a figure showing the atrioventricular valves in an open position in the diastolic phase of the cardiac cycle, and this shows the systolic phase of the cardiac cycle where the atrioventricular valves are in closed position, whereas the arterial valves are in open position. This is another diagrammatic representation showing the relations between all the four valves of the heart. This is the bicuspid mitral valve, this is a tri-leaflet tricuspid valve, the aortic valve and the pulmonary valve. There is fibrous continuity between the mitral and the aortic valve, that is there is a relationship between the anterior mitral valve leaflet and the non-coronary cusp and the left coronary cusp of the aortic valve, and there is a aortomitral content, that is a fibrous continuity between these two valves. This occurs due to the absorption of subaortic conus during the embryonic development. There is presence of subpulmonary conus, and thereby the pulmonary and tricuspid valve do not have such fibrous continuity. The septal leaflet of the tricuspid valve is in relation with the non-coronary cusp of the aortic valve. The anterolateral and the posteromedial commissure of the mitral valve are related to the right and the left fibrous trigone. As you can see over here, this is the right fibrous trigone and here will be the left fibrous trigone. This is the central fibrous skeleton of the heart. So now we will go in detail about the anatomy of the mitral valve. Andreas Vesalius coined the term mitral valve for left atrioventricular valve from its resemblance to the plain view of the bishop's mitre. This is the bishop's mitre, that is the headband that the bishops wear. So because of this, the name mitral valve was given to the left atrioventricular valve. It has multiple components and complex mechanism to work properly at the time of systole and diastole. As you can see in this figure, there are two leaflets, the aortic leaflet and the mural leaflet. This is a figure showing the mitral valve apparatus. We will see that in detail in the further slides. So, the mitral valve apparatus has two valve leaflets, the aortic leaflet or the anterior mitral valve leaflet, which is in relation to the aortic valve, and the mural leaflet, that is the posterior mitral valve leaflet. Then there is the subvalvular apparatus, which consists of the papillary muscles and the tendinous cords. Then there is aortomitral curtain, as I have already described earlier, which extends from the aortic annulus to the base of the anterior mitral valve leaflet. There is endocardium, which is the continuous structure sheathing the interior of the atrium, ventricle and being continued over the leaflets of the valve and also over the subvalvular apparatus. So this is the atrial view of the mitral valve as we see from the left atrium. So this is the anterior mitral valve leaflet. As you can see that it is attached to 1/3 of the circumference of the annulus, but it has its height is larger than the posterior mitral valve leaflet, whereas posterior mitral valve leaflet is attached to 2/3 of the circumference of the annulus. So again in this figure we can see the aortomitral curtain, the NCC and LCC of the aortic valve, the anterolateral commissure and the left fibrous trigon, the posteromedial commission and the right fibrous trigon, and this is the annulus fibrosus of the mitral valve. The annulus of the mitral valve, instead of having a planar configuration, the annulus has a three-dimensional saddle shaped configuration. As you can see in this figure, the two lowest point of this saddle shaped structure lies at the level of the two fibrous trigon, and the two highest points are located at the midpoint of the posterior mitral valve leaflet and the midpoint of the anterior mitral valve leaflet. The annulus is thinnest at the insertion site of the posterior leaflet, and thereby the maximum dilatation occurs at this point during the ischemic MR or any cause leading to left ventricular dilatation. The plane of the mitral valve annulus, as you can see in this figure, the plane makes a 120-degree angle with the plane of the aortic valve annulus, and this is called the aortomitral angle. If this angle is less than 100, then the inflow is superimposed with the outflow track, and this leads to facilitating the abnormal systolic anterior motion of the anterior leaflet and thereby obstructing the left ventricular outflow tract. So, the shape of the annulus varies throughout the cardiac cycle. During diastole, as you can see in this figure, it is grossly circular. That is, the anteroposterior diameter is almost equal to the transverse diameter, whereas in systole, the shape of the annulus is kidney shape. The transverse diameter is more than the anteroposterior diameter. Now, it is very important to know the structures that are in close relation to the annulus of the mitral valve during mitral valve surgery. So, one of the most important structures is the left circumflex artery, which runs between the base of the left atrial appendage and the anterior commissure, 3 to 4 mm from the leaflet attachment. That is here, and then it moves away from the rest of the posterior annulus. Another vital structure is the coronary sinus that skirts the attachment of the posterior leaflet. It is initially in the lateral position and then crosses the artery and becomes medial closer to the posterior leaflet attachment but 5 mm superior to the annulus. So this figure shows here the coronary sinus in relation to the mitral valve. Again here, the bundle of His is located near the posteromedial trigon. As you can see over here that the bundle is located over here. This is the AV node, and from here the bundle of His will go like this, and this is the central fibrous body. The non-coronary and the left coronary aortic cusp are in close relation with the base of the anterior leaflet, as I have already described earlier. Now, the leaflets of the mitral valve, it comprises of two leaflets, the anterior leaflet or the aortic leaflet and the posterior leaflet or the mural leaflet. The larger anterior leaflet is semicircular and attached to 1/3 of the annular circumference. The smaller posterior leaflet is quadrangular and attached to 2/3 of the annular circumference. The leaflets are separated by two commissures, that is the anterolateral commissure and posteromedial commissure. The distance between the free edge of the commissures and the annulus is approximately 8 mm. It is important to keep this distance during the commissurotomy procedure. The anterior leaflet, also called the aortic leaflet, has a trapezoidal shape. From the base to the margin, two zones are clearly apparent. The proximal zone, called the atrial zone, is regular, thin and translucent. The distal zone, which is the zone of coaptation or the rough zone, is irregular because it has numerous chorda attached to its ventricular side and it is thicker. The two zones have a similar surface area. During diastole, the anterior leaflet divides the left ventricle into two functional areas, the inflow chamber and the outflow tract. The posterior leaflet is inserted approximately on 2/3 of the annulus to the crest of the ventricular wall. The free edge is deeply scalloped by two indentations separating three segments, the anterior, middle and posterior scallops, also called as P1, P2 and P3 respectively. It is done to facilitate valve analysis. It was described by Carpentier. By convention, the corresponding areas of the anterior leaflet are called A1, A2 and A3. Though the anterior mitral valve leaflet does not have any indentations, it is the parts A1, A2 and A3 are described corresponding to the P1, P2 and P3 of the posterior leaflet. And there are two commissures, the anterolateral commissure and the posteromedial commissure. The size of the scallops of the posterior leaflet differs. The largest is the middle scallop, that is the P2, and the smallest is the anterior scallop, that is the P1. P1 is usually a fixed structure and it is considered as a reference point for mitral valve analysis in mitral valve repair procedures. The posterior leaflet presents two zones. From its base to the free margin of the atrial zone is smooth and translucent, and the coaptation zone is again thicker. So this is a diagrammatic representation of the segments of the mitral valve. This is the P1, P2 and P3. As you can see, there are two indentations dividing the posterior leaflet into three parts, and the corresponding parts, though there are no indentations, are called A1, A2 and A3 in the anterior mitral valve leaflet. This is a surgical view. And there are two indentations and there are two commissures, the anterolateral and posteromedial commissure. So this is a surgical view of the mitral valve. Again you can see the three segments P1, P2, P3, A1, A2 and A3. The P2 segment is larger and two commissures, and here is a left atrial appendage. Now the suspension system of the mitral valve. The leaflets are connected to the ventricular cavity by a suspension system called the subvalvular apparatus. The suspension system has two functions. One is to facilitate the opening of the leaflets during diastole, that is active opening, and the other is to prevent the upward displacement of the leaflets above the plane of the annulus during systole. To accomplish these two functions, the suspension system consists of two structures which have different characteristics. First is the papillary muscles with contractile properties and the chorda tendineae with elastic properties. So as you can see in this figure, this is the mitral valve apparatus. These are the leaflets, valvular leaflets. These are the elastic tendinous cords, and this is the papillary muscles. This is the ventricular musculature. The papillary muscles are implanted on the muscular wall of the left ventricle at a junction situated approximately 1/3 from the ventricular apex and 2/3 from the annulus. So here is the attachment of the papillary muscles. So there are two papillary muscles in the mitral valve apparatus. The anterolateral papillary muscle, it consists of one muscle body. It receives blood supply from both the left anterior descending and the left circumflex artery, and so it is less prone to ischemia during myocardial infarction. Whereas the posterior medial papillary muscle, it has two muscle bodies, but it receives blood supply from either the right coronary artery or the left circumflex artery, and so it is more prone to ischemia during ischemic MR. The chorda tendineae extend from the papillary muscle to the leaflets. There are three types depending upon their attachment on the leaflets. This is a figure showing the three types of the chorda tendineae. First is the basal or the tertiary chorda, which are attached from the papillary muscle to directly from the ventricular wall to the base of the leaflet, that is over here at the attachment of the leaflet with the annulus. The basal chorda are attached at the posterior and the commissure leaflets mainly. The intermediary or the secondary chorda extend from the papillary muscles. The intermediate chorda are attached to the ventricular side of the leaflets between the attachment to the annulus and the margin of the leaflet. They reduce excessive tension on the leaflets. The marginal or the primary chorda are attached to the margin of the leaflets. The space between the marginal chorda does not exceed 3 mm and their attachment to the leaflet is often bifurcated or trifurcated. They act to prevent the leaflet prolapse. So Carpenter gave a functional classification depending on the leaflet motion for easier diagnosis and management of the mitral valve regurgitation, the pathology and its appropriate management. So for the first type is with a normal leaflet motion. The second is with excessive leaflet motion. The third A type is because of the restricted leaflet motion in systole and diastole both, and in third B there is restricted leaflet motion in systole. This is another diagrammatic representation of Carpentier's functional classification of mitral regurgitation type 1, that is with the normal leaflet motion. The example of this type of mitral regurgitation is either due to annular dilatation in ischemic MR or because of leaflet perforation, as for example in infective endocarditis. The type 2 is because of the leaflet prolapse. So in this, the examples are the myxomatous mitral valve, the fly leaflets leading to mitral regurgitation. The third is the restricted leaflet motion, leaflet opening in systole and diastole both, and the examples of this is the rheumatic heart disease, which is one of the common causes of mitral regurgitation. And type 3B is restricted leaflet motion only in systole. It occurs in ischemic MR or any thickening of the leaflets. So that was all about the mitral valve. Now we'll learn about the tricuspid valve. The tricuspid valve is the atrioventricular valve which lies between the right atrium and right ventricle, whereas the mitral valve was between the left atrium and left ventricle. The tricuspid valve is a part of the complex functional system that also includes right atrium, right ventricle, pulmonary circulation. It is generally a 3-leaflet valve with an annulus and its valvular plane facing towards the right ventricular apex. So mitral valve was a bicuspid valve, whereas tricuspid is a 3-leaflet valve. There were 2 leaflets in the mitral valve. So one important thing about atrioventricular valves is they go along with the ventricles. It is important to know this in congenital heart conditions such as CCTGA, that is congenital corrected transfusion of great arteries, where the morphological right ventricle and has the tricuspid valve, whereas the morphological left ventricle has the mitral valve. So the leaflets of the tricuspid valve, there are 3 leaflets: anterior leaflet, posterior leaflet and the septal leaflet. As you can see in this diagram, the anterior leaflet is the largest one, followed by the septal leaflet, and the smallest is the posterior leaflet. The septal leaflet is attached to the base of the interventricular septum and is relatively fixed. There are 3 commissures, so 3 leaflets, 3 commissures: the anteroseptal commissure, then there is the anteroposterior commissure and posteroseptal commissure. So the tricuspid valve is in relation to the membranous septum. So whenever you are operating for a ventricular septal defect, you will see that through the right atrium, when you retract the tricuspid valve, you will see the membranous septum, perimembranous VST, and you approach the VST through this. It was just an applied aspect. So in general, the tricuspid valve leaflets have a rough zone in the crescentic region where chorda tendineae are attached, and the broad basal zone at the apex of the leaflet and a clear zone. There are 3 commissures. The anteroseptal commissure, it lies between the anterior septal leaflet. Chorda are short and arises directly from the septal band or small papillary muscle. The basal attachment of the tricuspid valve at this commissure is at highest level at the membranous septum. The anteroposterior commissure, it lies between the anterior and the posterior leaflet. It is located roughly at the acute margin of the RV. The large anterior papillary muscle identifies this commissure. Then there is posteroseptal commissure. It lies between the posterior and septal leaflet, the large chorda papillary muscle and a fold in the septal leaflet. It has a wider spread. Now the subvalvular apparatus of the tricuspid valve, it differs from the subvalvular apparatus of the mitral valve, as in mitral valve there were 2 set of papillary muscles, and in tricuspid valve there are 3 papillary muscles: the anterolateral papillary muscle, the posteromedial papillary muscle, and the septal, or also known as the muscle of Valve-Cce, or the conal papillary muscle, or the infundibular papillary muscle. This is a diagrammatic representation showing all the papillary muscles. See, these are the chorda tendineae. So here is the posterior papillary muscle, as you can see over here. This is the medial papillary muscle, and this is the anterior papillary muscle. Then there is a prominent muscular band in the right ventricle, also known as the moderator band. It was said that the moderator band moderates the right ventricle, that is, it stops or avoids the dilatation of the right ventricle, which was then found out to be wrong, but still the name persists depending on that the moderator band is named because they believed that it used to moderate the right ventricle. This is the moderator band. It is a prominent structure. It can also be seen in the echo and one of the ways to identify the morphological right ventricle. Then there are the chorda tendineae, the suspension system. Now the tricuspid valve annulus, it is a heterogeneous, almost virtual structure composed of intermixed fibrotic and elastic fibers in continuity with the leaflet tissue, the atrium and the ventricle. It is a complex 3D structure, as you can see over here. It is non-planar, elliptical, saddle-shaped annulus. The annulus fibrosus is not visible from the atrial view because it is deeper and 2 mm external to the hinge. It is more of a landmark rather than a fibrous ring. So, absence of encircling fibrotic structure, as it was present in the mitral valve, explains the large changes in the tricuspid orifice continuously during the cardiac cycle. Reduction in the orifice parameter of the tricuspid valve is not uniform, and annulus corresponding to the septal leaflet reduces least, as the septal leaflet is attached to the interventricular septum, which is relatively fixed. The reduction in the annulus at this site is less, and the maximum reduction occurs in the posterior leaflet. This is the posterior leaflet. As the septal leaflet, the reduction is minimal. The size of the tricuspid valve changes dramatically during the cardiac cycle. During diastole, it is grossly circular, and during systole, it is ovoid in shape. Now, the annular dilatation, which usually occurs in functional TR due to the RV dysfunction, due to any pathology leading to secondary TR, that is a functional TR, the annular dilatation occurs usually in this direction, in the direction of the anteroposterior commissure. So, this is how the diagram represents the dilatation of the tricuspid valve. So, most of the tricuspid valve repair techniques focus on the reduction of the tricuspid valve in this segment only, that is from the anteroseptal commissure up to the posteroseptal commissure, whether it is the de Vigas technique or any tricuspid valve repair ring techniques. Another reason is that the AV node and the coronary sinus are in close relation to the septal leaflet of the tricuspid valve, and therefore during the repair techniques it is wise to avoid this area to avoid injury to this vital structures. Now, again the anatomical relations of the tricuspid valve are important during the tricuspid valve surgeries. So, this is a diagrammatic representation. This is the anterior leaflet, septal leaflet and the posterior leaflet of the tricuspid valve, as we see from the right atrium. The anterior leaflet and the part of the posterior leaflet are related to the right coronary artery at this segment. The posterior leaflet and the septal leaflet are related to the coronary sinus. Now, AV node is in close relation with the septal leaflet. So, the AV node lies in the triangle of Koch in the right atrium. The triangle of Koch, the margins of this triangle is formed by the coronary sinus, the septal leaflet of the tricuspid valve and the tendon of Todaro. So, the AV node lies at the apex of this triangle and is relation to the septal leaflet. Now, this is the interatrial septum and the mitral valves. The septal leaflet, the interatrial septum and the mitral valve. The non-coronary cusp of the aortic valve is related to the septal leaflet. So, it is vital to know all the surgical relations or anatomical relations of both the valves, the mitral and the tricuspid valve, to avoid injury to any of the vital structures during the valvular heart surgeries. Thank you.